Good morning, friends. The next CME lecture in this series is by none else but India's top rheumatologist from Delhi, Dr. Aroop Mukharjee, who will be speaking on DMARDs demystified. Rheumatoid, osteoarthritis, and rheumatoid-like conditions are the commonest conditions that an orthopedic surgeon faces in his clinic. Dr. Mukherjee teaches you how to correctly balance the various DM, ARDS in the right doses to get good benefit from long-term use of these drugs. Over to Dr. Aroop Mukherjee.
About rationale of DMARDs in orthopedics. Now, what does an orthopedic OPD consist of? Let us think about this. Apart from infection, trauma, and congenital anomalies, every other patient is a patient of rheumatology in our orthopedic OPD. Even healing of fractures and wound healing is delayed in arthritic patients or rheumatoid patients. 1 in 3 women and 1 in 5 men are affected by rheumatological disorders. So don't think that bone pain is the primary symptom of rheumatology. Again, I will repeat, don't think that the bone pain is the primary symptom of rheumatology. A hypertension is also autoimmune disorder. A hypothyroid patient is also suffering from autoimmune disorder. An IBS patient is also suffering from autoimmune disorder. And patients who's suffering from diabetes is also suffering from autoimmune disorders. So, an autoimmune disorder is the primary cause of all unexpected results in orthopedics. So I told you that as which has not been taught in our graduate and postgraduate degree courses is that we see autoimmune disorder more frequently than we have been taught about. Now let me see that what is the regimen. Now this I have taken from a textbook of medicine. What is the regimen? The dose of the drug with frequency and timing of its administration constitute the dosage regimen. Each prescription should be treated as an experiment in which you try to find a regime that produces the best therapeutic effect with minimal side effects. That is the purpose of that is the sole purpose of the treating doctor. Principles, what are the principles? That we start the doses at the lower level of the recommended dose. Increase the dose gradually, monitoring the therapeutic effect at regular interval, looking for adverse effect. Think of the drug interaction and inappropriate combinations before you start writing the medicine. Like, we don't write calcium and iron on the same day. If you want to give calcium and iron, then give calcium on the day, and the next day you give iron, so that they do not interact. Take particular care with drugs with low safety index. And the drug interaction is also like that. Don't give folic acid on the same day as you give methotrexate, because both are antagonists to each other. So I give folic acid on Monday and methotrexate on Tuesday, so that they don't interact. Specially take care with the medicine with a low safety index. That means cytotoxic medicines has to be given in minimal doses. And that is the reason I give methotrexate in very low dose, and that too in the morning when you get the maximum absorption, and the dose is only 2.5. I'll discuss it later on. Now, when you approach a patient, consider that my prescription has got a long list of medication. So how to enhance the patient's compliance to take that many medicines? That means you have to write the prescription in a way that every medicine is used, but used selectively. The best part of the DMARDs is that they are collected in the body. They have got a collection in the body, and that means you don't have to continue with the same doses for many weeks. Gradually, as the body has got enough doses, you can only give up the top-up medications. So the therapeutic approaches to a patient is, you have to also consider that the patient has got a poor absorption because of the IBS. There's altered tissue distribution because of the fibrosis and adhesions in the various area, like that, like you have got a periarthritis of the shoulder, which has got a fibrosis all around the shoulder. So the drug penetration in that area will be very poor. Somebody has got an enthesopathy in the heel, which is full of fibrosis. So the drug penetration in that area will be very poor. So you have to give medications with blood thinners so that your drugs also reach the area of poor circulation. Now there is altered protein binding like calcium. Calcium, if given with protein, is absorbed in elderly. You cannot make calcium get absorbed in an elderly patient. Yeah, calcium can get absorbed in children and in pregnant ladies if you give them even also like calcium carbonate. But that is the body's acceptability to calcium. But as the rheumatoid patients, they have a tendency to lose calcium and protein. And how would you supplement calcium and protein? By the giving calcium supplements which are adhered to protein. So always give supplement of protein with calcium. Now, reduced renal eliminations, because even in so many cases, there is an altered renal function as altered hepatic function in all the patients of rheumatoid arthritis. So when we give these DMARDs, you will get a more retention of drug in the body. So you start giving the medicine in low dose so that you rarely see any toxicity due to the drugs. Now, before starting my regime, this is the list of, I also told you what to get it done beforehand so that we can compare these results after or during the course of the treatment. CBC, ESR, CRP, fasting sugar, HbA1c, SGAPT, serum alkaline phosphatase, creatinine, uric acid, TSH, lipid profile, PT, APTT, and INR, because these are the basic tests you start with so that you can compare it in the course of the therapy. X-ray pelvis AP view, X-ray pelvis AP view in 30-degree flexion at the hip joint, and you also ask the radiographer to label the X-ray which is in 30-degree flexion so that you can compare the 30-degree flexion pelvis X-ray with the next which you get after 2 months. Now, whenever you see a patient of avascular necrosis or arthritis, always imagine that this is a whole body disease. Nobody should blame you that because of the medication, I have developed a fatty liver or renal calculus, or these were not there. So if you get a beforehand ultrasound of the whole abdomen and document it that the patient has already got fatty liver grade 1, or he has got a 4 millimeter calculus in the left or right kidney, he has got inflammatory bowel disease or PCOD in the younger patients, and uterine wall thickening. So these are the things which you like, which I also document and give it to the patient beforehand, before starting the treatment, so that your treatment, due to ignorance of the other doctors, does not get blamed for developing these things. These are the findings commonly seen in an arthritic patient. What I'm talking about is a fatty liver, renal calculus, irritable bowel syndrome, PCOD, uterine wall thickening. These are the case. Whenever you treat arthritis, you get an ultrasound annually to the patient, so that the patient should know beforehand that she came or he came with the same problems. Now, MRI of the pelvis to be repeated every 6 months to see the synovitis, to see the bone edema and its extension, area of avascular zone. What does the MRI tell? I'm just highlighting those things. Deformity and subchondral fracture, joint space width and acetabular changes, and changes in the sacroiliac joint. So these are the changes, and in your prescription you should also mention, and a doctor should be able to read an MRI, a treating doctor. See, if you start seeing avascular necrosis frequently, then you will come to see all these changes happening. Sit with the radiologist who has done an MRI reporting, and he will point out all these things in a avascular necrosis patient. Now, this is my regime, an explanation to the use of every drug and supplement. My regime, explanation to the use of every drug and supplement which I write in my prescription. Now, this is the fasting medication. What are the, why I give these medicine fasting? Because fasting ensures maximum absorption. And when the dose of the drug is minimal, then you can't mix this medicine in with the food stuff in the tummy. And that is the reason fasting ensures maximum absorption. There is no chance of food interaction with the drug. The dose of the medicine is minimal, that is 2.5 milligram, 5 milligram, micrograms as in thyroxine. So what we say, our hypothyroid patient, take the thyroid medicine early in the morning fasting, because the dose is in micrograms. And as we all know, our anti-acidity medications are also given fasting. So my fasting medications now, when we come to the, see, I give folic acid 5 mg on Monday, Wednesday and Friday, and methotrexate 2.5 mg on Tuesday, Thursdays and Saturdays, because folic acid and methotrexate are antagonists to each other. So one day you give folic acid, the next day you give methotrexate. And remember, folic acid will always neutralize methotrexate. So they should be given on different days. Then vitamin D, 60,000 units on Sunday. That makes the whole list. 7 days a week, Monday, Wednesday, Friday, we give folic acid. Tuesday, Thursday, Saturday, we give methotrexate. And on Sunday, we give vitamin D. Pantoprazole or any anti-acidity H2 receptor blocker should be given fasting every day. As well as in avascular necrosis, warfarin 2 mg is given daily except on Sunday, because sometimes continuously giving warfarin may enhance the bleeding susceptibility. So warfarin has to be given 2 milligram every day in the morning fasting, except on Sunday. The dose is very low, 2 milligram. Now, what are the after lunch medication? Medications which are of the large size tablets. The possibility of gastric irritation like we see in HCQS. Salazopyrin, that means SARS-DS, reduces the gut inflammation, and probiotic rehabilitate the gut health. So most of the patients with arthritis, they have bowel inflammation. So salazopyrin not only reduces the bowel inflammation, and probiotics rehabilitate the gut health. So it also enhances the protein absorption and the calcium absorption. So salazopyrin is not only a DMARD but also maintains the gut health, so that there is a good absorption of protein and calcium and iron from the gut. Then we come to leflunomide. Leflunomide is hepatotoxic, as we all know. So its absorption with the food minimizes the liver damage. So that is the reason after lunch medications are qualified to be those tablets who does not irritate our bowel, and in DMARDs, by taking DMARDs. Now, what are the after lunch medication? Vitamin A capsule, 5,000 units alternate days, and tablet leflunomide 20 milligram alternate days, capsule vitamin B12 1500 micrograms alternate days, hydroxychloroquine 400 milligram alternate days, and sulfasalazine 1 gram alternate days, and capsule probiotic which contains more than 3 billion spores on alternate days. See, these medicines have been written in a way that the effect is synergistic. Now, leflunomide is synergistic with vitamin A because leflunomide is a cytotoxic medicine, and the toxicity is reduced by taking antioxidant like vitamin A. Capsule vitamin B12 with hydroxychloroquine, because hydroxychloroquine causes peripheral neuropathy, and that is the reason optic nerve neuropathy also, and that is the reason hydroxychloroquine is not advised to be taken more than 6 weeks together. But here we are always concomitantly giving vitamin B12 1500 microgram. One day is hydroxychloroquine, the next day is vitamin B12. Similarly, sulfasalazine is a gut is a drug which will reduce the inflammation in the gut. So it is always given with probiotic, so that probiotic also causes reduction in the gut inflammation. So sulfasalazine and probiotic are given alternate days. So one day you give sulfasalazine, the next day you load the stomach with probiotic. And the regular probiotic is not going to help, because the probiotic, the spore level, number of spores should be more than 3 billion spores per capsule. So a doctor has to go through the medication and details of the drug before advising. Now, after dinner medication, I give no sedative, no painkillers. Now, tablet iron supplements, which also contain folic acid, should be given on Monday, Wednesday, Friday, because all the iron supplements contain folic acid. And as I told you, that folic acid is an antagonist to methotrexate. So methotrexate is to be given on Tuesday, Thursday, Saturday. So don't give iron on Tuesday, Thursday, Saturday. Give iron tablets on Monday, Wednesday, and Friday. Similarly, calcium citrate, calcium and iron cannot go together. So calcium citrate, because we have already given acidity medicine in the morning, so calcium carbonate will not be absorbed, because calcium carbonate needs breakdown by the acid of the stomach, HCl, into calcium and carbonate, and then only it will be absorbed. But this is not true for calcium citrate. So 1.2 gram of calcium citrate is given on Tuesday, Thursday, Saturday, which is not on Monday, because Monday it will they will neutralize with the iron tablets. So give calcium citrate on Tuesday, Thursday, and Friday. Now, vitamin E is an energy producing supplement and prevent nocturnal cramps. What happens in rheumatoid arthritis? Because of the pain, there is a reflex inhibition of energy producing system in the body, and that means the mitochondria is not producing that much of energy as we need. Why? That is the reason. In winters, arthritis patients suffer most, because in winter we need internal energy to keep our body warm, and our system of energy producing is reduced in rheumatoid arthritis. That is the reason our feet and the distant part of the body from the heart becomes cold in rheumatoid arthritis. And that is the reason I always say that our body does not produce that much of heat in rheumatoid patients as it was producing, or as it is producing in a healthy individual. So when you touch the feet of these rheumatoid patients, you will find them cold and clammy. So tell them to keep their feet warm. Now, fourth medicine is methylprednisolone, 4 mg for a month, and then 2 mg to continue. Now, low dose of steroid, is itself a very good DMARD, and steroid taken early in the morning also reduces the morning stiffness. But we cannot take steroid fasting in the morning. So I prefer giving methylprednisolone 4 milligram at night after the dinner for 15 days or sometimes for a month, and then reduce it to 2 mg to continue. And one capsule eflapin 50 mg for periosteal or the dull bone pain. Enthesopathy, eflapin is doing very is quite effective. Now, when we are talking about this, we should be asking about what the frequently asked questions about avascular necrosis. Now, about etiology, is it truly idiopathic? No, it is not idiopathic. You have to find out the reason. Why does it happen to a certain part of the population? A lot of people take steroid, but everybody does not get it. Lot of people suffer from rheumatoid arthritis, but everybody does not get avascular necrosis. So both of these things can be justified by the idea that avascular necrosis happens to those people who have a solitary blood supply, or who have got a vascular anomaly in the femoral head supply. And secondly, if there is an anomaly as well as arthritis, then they will get avascular necrosis. And that is the reason the incidence is very erratic, that all the people do not suffer from the same disease, but people who have a vascular anomaly as well as suffer from arthritis may happen to suffer from avascular necrosis. Now, where did I get this idea from? I got this idea, I told you, that from avascular necrosis of the lunate. Now, 1/5 of the lunates have a solitary blood supply. That means out of 5 people, one man, one person, or one woman will have a solitary blood supply from the dorsum of the lunate. And lunate, as you see, is entirely an intra-articular bone with both the surfaces articular. So 1/5 of the lunate is supplied, 1/5 population of the lunate is supplied from a dorsal solitary blood vessel. When these dorsum of the wrist suffers from synovitis, there is a secondary thrombosis of the dorsal blood supply of the lunate. And that is the reason the lunate goes into avascular necrosis. Now, if you open a book of hand surgery, you will find that they are not talking about blood supply. They are talking about how to reduce the lunate loading. So, that is surgical method, how to reduce the loading. I agree that you should reduce the loading, but there is no mention about how to improve the blood supply of the lunate, which my regime does. Now, third is, can one use the regime after the collapse or deformed head of the femur? Yes. There is a reversal of calcium back to the bones. So far, what is happening was calcium was coming from the bone to the blood in order to maintain a level of 9 to 11 milligram%. But now, because of the reversal, now bone is asking back the calcium. So the bone starts absorbing the calcium from the blood. So as soon as this happens at the night, so when the blood calcium dips below 7 milligram, then there is a muscle cramp and the patient will get up at the middle of the night, because a normal calcium is necessary for contraction of the heart as well. And that is the reason the body does not want to lose the blood calcium. So in order to maintain the blood calcium, it drains the bone. But now with the treatment, the bone wants back the calcium and starts getting the calcium absorbed from the blood. And that is the reason we get nocturnal cramp. When the patient starts getting muscle cramp at night. When the patient complains of the nocturnal muscle cramp, I am happy, because now I have started reversing the arthritis. The arthritis which has drained my bone of the calcium is now giving back the calcium to the bone. So you should not get upset with nocturnal muscle cramp. Try to change the brand of the calcium in order to enhance the calcium absorption. So protein, calcium, malnutrition is the main thing of chronic rheumatoid arthritis. Thank you very much. I think this is the message I wanted to give to all my listeners, that whenever you treat arthritis, you are treating the entire patient.